Hi, I'm Sophie Katz. I'm one of the Pediatric Infectious Diseases Fellows at Vanderbilt University Medical Center, and I am starting as faculty in July as the Associate Director of Pediatric Antimicrobial Stewardship, and will be leading the outpatient antimicrobial stewardship efforts for the Children's Hospital. So today we're going to be talking about outpatient antimicrobial stewardship, and first we'll go over some background about outpatient antibiotic use and antibiotic resistance, and then we will talk about some of the drivers of inappropriate outpatient antibiotic use, and finally we'll talk about some options for combating antibiotic resistance in the outpatient setting. So first, why should we care? I'm going to start with a case of a patient who I took care of earlier this year. She's a 22-month-old female who came to Vanderbilt because she had discharge coming out of a nasal dermoid cyst, and the culture grew E. coli, and her antibiotic susceptibility test came back as this. So what would you use to treat it? We ended up treating her with Piptazo, but then she ended up getting resistant to that, and we had to use meropenem to complete her course of treatment. So the problem really is that as time goes on, the number of antibiotic drugs that are coming out on the market is decreasing, and the number of resistant bacteria is increasing, and that's really setting up the perfect storm for antibiotic resistance and worsening antibiotic resistant bacteria. And in 2013, the CDC put out this list of antibiotic resistance threats, which I'm not going to read all through, but I just want you to appreciate that it's a pretty long list. And if that's not enough to scare you, just look at the news. There are many articles talking about the threats of antibiotic resistance. One thing that's come up recently is this article that said that by 2050, if antibiotic resistance keeps increasing at the rate it's increasing now, superbugs could kill 10 million people a year by 2050, which is about the same amount, if not more, than the number of people who die worldwide from cancer every year. And there was also this story about a woman in Nevada who died last year from an antibiotic-resistant bacteria that was resistant to all 26 antibiotics that were possible to treat it. To make matters worse, really the number of new antibiotics being approved by the FDA has been dwindling since the 1980s, going from about 16 antibiotics in 1983 to 1987 per year to about 2 antibiotics that were approved later on this graph. And so the big problem is that it's not economically important for pharmaceutical companies to make new antibiotics. It's the one drug that you use for a short period of time, and the more you use it, the more likely you are to develop resistance against it, so it's something that you don't want to be on forever. And really, we've done a pretty good job of improving antibiotic use in the inpatient setting, but it's time now to start thinking about the outpatient setting. The majority of antibiotic expenditures occur in the outpatient setting, with over 60% of expenditures in that setting. And also about 80 to 90% of antibiotics taken are in the outpatient setting. One thing that's kind of interesting is that during the winter months, antibiotic use increases. And that is probably not because there are more bacteria in the winter months, but there are more viruses, and people are probably inappropriately treating some of the viruses with antibiotics. Studies have shown that about 50% of antibiotic use is inappropriate in the inpatient setting, and about 30% is inappropriate in the outpatient setting. And that's when we think about choosing the wrong antibiotic for what you're treating, or treating an illness that doesn't need an antibiotic with an antibiotic. And if you look at drugs that are written for the wrong dose or the wrong duration, that number actually goes up to closer to 50% in the outpatient setting also. One thing to think about that really explains the problems with inappropriate antibiotic use in the outpatient setting is the antibiotic treatment for pharyngitis in children. Studies have shown that about 30% of pharyngitis in children is caused by bacteria, by group A strep, and yet about 60% of children who go to a doctor with a complaint of pharyngitis will get treated with an antibiotic. So there's about a 30% difference of inappropriate antibiotic use in that setting. This map shows the United States and rates of antibiotic use between each country, and antibiotics prescribed per 1,000 population. In Tennessee, the antibiotic prescription rate for all ages is about 1,195 prescriptions per 1,000 people. So that's more than one prescription per person per year. And in children, that number is about 1,165 prescriptions per 1,000 people. But if you look at the national average, the antibiotic rates are about 836 prescriptions per 1,000 people for all ages and about 790 prescriptions per 1,000 people for children. And so if you think about that, the Tennessee prescribing rate is about 50% higher than the national average. And this is all compared to Sweden, where the antibiotic prescribing rate is only 388. And I can't imagine that they actually have fewer bacterial illnesses in Sweden. It's probably that we are doing something different in the US. This map shows the graph of the state of Tennessee, and you can see different shades of red based on how much antibiotic prescribing is happening in each county. And I just want you to appreciate that even counties adjacent to each other have different antibiotic prescribing rates. So it's not necessarily that there are more infections in one part of the state than another, but it's not all bad. This graph shows a line graph of antibiotic prescriptions and trends from 2011 to 2016. And if you look at the graph, you can easily see that the rates of antibiotic prescribing in children have decreased over at least from 2011 to 2014. So we are doing something right, which is encouraging. And there's more and more research and focus coming out about the collateral damage that antibiotics can cause. So we know that it causes increased healthcare costs, alterations in the gut microbiome. It contributes to the C. difficile epidemic, and they can definitely cause adverse drug events also. And in the past probably 10 years, there have been new mandates coming out from government organizations like the Centers for Medicare and Medicaid Services, the Joint Commission, and the CDC, as well as the White House, talking about how we really need to improve what we're doing with antibiotic use. Under the Obama administration, the White House came out with a plan for combating antibiotic resistance with goals to reduce outpatient antibiotic use by 50% by 2020. And that year is pretty fast approaching, and I don't think we're actually anywhere close to that goal.